So good morning, everyone. It is still morning. Welcome to our webinar, Elder Abuse and COVID-19 Challenges and Opportunity. My name is Josie McPherson. I'm the Senior Director of System Advocacy here at the New York State Coalition Against Sexual Assault. If you're having any technical issues, please email me at jmcpherson, that's JMCPHERSON, at NYSCASA, NYSCASA.org, or you can also email Chow Miller at cmiller@NYSCASA, NYSCASA.org. So this webinar will be recorded and shared on our website later on. And I would like to introduce our presenter now, Tracey Siebert-Konopko, the Program Manager for Statewide Education and Training for the Upstate Elder Abuse Center at Lifespan. Welcome, Tracey.
Hello, thank you. Yes, I'm Tracey Siebert-Konopko. I am a social worker at Lifespan in Rochester, New York. I use she, her, and hers pronouns. And I've been at Lifespan for a good 12 years now. And if you're unfamiliar with Lifespan, we are a non-residential domestic violence provider in Monroe County, and we have over 30 different programs in-house, all dedicated to working with older adults and their caregivers. So it's a very decently sized not-for-profit in Rochester. And we've been working with elder abuse and the elder abuse population since 1986. And the program has grown from roughly a 2-person program to now we have almost 20 people amongst our 3 core programs within the Upstate Elder Abuse Center at Lifespan. And those include Elder Abuse Prevention Program, which is the original program. And in that program, we do case management and intervention in a 10-county region. So Monroe and the surrounding counties, we do education and statewide training. We also have a SCAMS program. So the SCAMS program is available in Monroe and I think 11 surrounding counties at this point. And our SCAMS program also does statewide training and education. And then we have an enhanced multidisciplinary team program. That's a statewide program, and it's moving into every single county in New York State. So that's a really cool thing. I mean, it's multidisciplinary. So we have attorneys, both civil attorneys and district attorneys' offices, law enforcement and adult protective services, office for the aging, other advocates, and kind of like a couple of the hallmark features are not only the coordinator for each team, but also a forensic accountant and a geriatric psychiatrist, both of whom are on retainer to provide consultation for those teams. So it's a really cool program, and it just shows kind of the breadth of what we do here at Lifespan and in the elder abuse prevention and Upstate Elder Abuse Center at Lifespan program. All right, we're gonna talk just an overview of what elder abuse even is. And the fact of the matter is that you all as advocates, you're already gonna kind of know some of these signs and symptoms. It doesn't really matter what population you're working with. If someone is a survivor, there are certain things that become very prominent and prevalent in their reaction to things, in how they present, in the things that they may say to you, in the things that you see that their caregivers or friends or family and how they interact with the potential survivor. For elder abuse, we're going to be talking about people aged 60 and older. So one of the challenges with elder abuse is that it is not well defined across the nation. So some places will refer to people aged 55 or 50 and older as elder abuse. Some people go 65. I've even seen as late as 75 used as an elder abuse litmus. In New York State, we're talking about 60 and older. It includes intimate partner violence and any abuse by trusted individuals. So most of the time, the vast majority of our cases, the perpetrator is a family member, most of the time an adult child. So we also have seen paid caregivers be abusive. We've seen friends, other family members, professionals, other professionals, not just paid caregivers, but other professionals as well, who target and take advantage of older adults because of a perceived or actual vulnerability that they're experiencing. So the 5 different types of abuse are psychological or emotional, financial, neglect, physical, and sexual. So I think, the biggest difference with this versus IPV is really that neglect piece. And that's not to say that people can't be neglected who are younger. However, the more people who are neglected will be older adults who have become more dependent on others as they have aged. So with neglect, what we would specifically be talking about there is active, passive, or self-neglect. Active neglect is when you have a caregiving responsibility and you choose not to do it. So you see someone in need and you do not help them. It's kind of like the finale of Seinfeld, right? It's the standby person that doesn't assist. Sometimes active neglect can even be more insidious, and it's not just a lack of action, but it's an actual action. So, for example, there's a very famous in the elder abuse world case of an older individual in Washington State. And what happened to Ruby was that her son had neglected her for months, and she ended up passing away. She died from her injuries resultant from the neglect that she experienced at the hands of her son. And when investigators went to look into this and try to figure out what was going on, they discovered that not only were there earplugs on the table next to his chair, so when he would hear her screaming, he would put the earplugs in because she got too loud. So that's an active form of neglect. Additionally, they found alcohol and alcohol swabs, like isopropyl alcohol, next to her bed that he had been using to clean out her bed sores. So that would have caused her an exceptional amount of pain, and it's not the appropriate way to have cared for her. So that's an active neglect scenario. It gets pretty gritty and pretty insidious. Passive neglect is folks that are, in the truest, purest sense of the word, ignorant of their caregiving responsibilities or duties. And now, to be fair, in New York State, there is no law that someone has to care for someone else in their home, unless it's, of course, a minor or a dependent other as determined by a court of law. But for the most part, I'm not responsible for what my husband does or doesn't do around the house, you know? If I were to live with my parents, there's no legal precedent set that says that I have to provide them care just because I live in the same home as them. Now, legal precedent and ethical are two very different things. And of course, from an ethical standpoint, but from a criminal justice standpoint, not so much. Passive neglect is folks that just simply aren't trained to care for older adults. So, you know, the vast majority of caregiving in the United States is done by family members and friends. It's not done by professionals, because the vast majority of older adults live in the community and not in assisted living or skilled nursing facilities. So that's one of the kind of, I think, stereotypes that goes around, that older adults have dementia, they're senile, and they live in a nursing home. False. Only about 5% of older adults live in skilled nursing or assisted living facilities. So the vast majority of caregiving, therefore, is done by non-professionals. These non-professionals, family members, friends, may be well-intentioned, but have not been trained in proper transferring, for example. So moving someone physically from a seated to a standing position, or from a seated position in a wheelchair or other device to a bed or to a recliner or something along those lines, or to the toilet. Most people are not trained in wound care. Most people are not trained in nutrition and health. So in those cases, the abuse is not intentional. Some people are also emotionally ill-equipped to care for someone. Not everyone is a caregiver by heart or by trade. And sometimes, especially if there are strained family circumstances, it can be additionally difficult to render care and help to someone if you don't really like them. You can love someone and not like them. Everyone realizes that. Everyone knows that. It can be very difficult to provide care. And especially when someone does have dementia symptoms and they start to have memory loss, or they start to become maybe combative with caregivers because of damage to the frontal lobe that occurs with a lot of forms of dementia, that can add a layer to the inability to care for. So financial abuse is the most commonly seen form of abuse. And for our clients, financial abuse, I'm talking about stealing and theft and whatnot from loved ones. What differentiates financial elder abuse from a true scam is the relationship. So a relationship with a scammer is a one-way relationship. The older adult may think that they have one with the scammer, but the scammer is only in it, and it originated out of a desire to scam the older adult. Financial elder abuse, the relationships are a lot more organic and a lot more mutual. And I think everyone that's on here can attest to, within the work that they do, love is not a light switch. You know, a person can do wonderful things in a relationship and truly horrible things in a relationship, but we don't love them based on the fact that anyone in our lives is good or wonderful or kind to us all of the time. That's just not realistic. So in elder abuse cases, there is a lot of give and take, and sometimes that does get skewed, of course, to more give and more take. And that's really where the financial abuse is different from a scam, is that there is some level of reciprocity on one and not on the other. It's estimated, and this is an old number, so as you can see, this is from 2011 results from a 2008-2009 study. The New York State Prevalence and Incidence Study, to be exact, was conducted by Lifespan, Cornell Weill, and the Department for the Aging in New York City. And it was estimated at that time that a prevalence rate of 7.6% of older adults were abused or will be abused each year. And that equaled 260,000 older adults. But by today's numbers, because there are more older adults today than there were 10 years ago, that number would be closer to 300,000 now. So roughly 300,000 older adults each year are surviving elder abuse situations and sometimes not surviving them. And again, I'm not going to go into the details of emotional, physical, or sexual neglect, but what I will do is discuss kind of what differentiates elder abuse from younger forms of family violence. Because I think everyone on this call probably has a pretty decent or even better understanding in some situations than I do on those things. Let me find my cursor here. There we go. So let's talk a little bit about the physiological changes that occur with aging. Now, this is not meant to stereotype because everyone ages slightly differently and at different speeds, and certainly, but everyone does age. You know, that's inevitable. If you are alive long enough, you're gonna get older. And certain changes will occur to your body as you age, regardless of how good you keep yourself in health, you know, how much you exercise, what you eat, really doesn't matter so much. It may prolong or lengthen your functionality. It may help to slow down the aging process in some ways, but it's not going to stop it or arrest it. So different things. So with our muscles, as we age, we get a decreased muscle mass. Now, muscle is how it helps a lot of our medications to be metabolized, which is one of the reasons why you see medications being so potentially dangerous in older adults. There's an entire scale, the Beer scale, that's used to guide physicians and also pharmacists regarding safe and unsafe medications. So certain psychotropics are not that safe for older adults. There's certain types of sleeping pills that are not good for older adults because their muscles are not helping, their muscular tissue is not helping them to metabolize those in the same way that younger people can. So they have a more extreme effect on older adults and can interact with their bodies in a very different way. And since we're all chemical masses, anytime we're putting chemicals in our body, there's this soup of things that can go on and can really kind of go wrong. And also muscle mass, the lack of muscle mass, the ability to fend off an attacker. So if someone is coming at you or is threatening you in any way, your ability to fend off an attack is going to be diminished as your muscle mass decreases. Your skin becomes less elastic and it becomes thinner. That means that injuries occur more quickly and can be more severe for older adults. So I use as an example all the time, my grandmother who's 94 years old. And if I were to just bump into her and knock her over, her injuries are going to be incredibly severe versus if I bump into my 5-year-old and knock him over. And that is due entirely to the way that our bodies are designed and other things as well, of course, other health determinations as well. Here we go. So the skeletal structure and joints, of course, our bones become less dense. And anyone who is cis female, I'm not really sure how it translates beyond that. But cis females, osteoporosis is still worse for us. It is rampant. It is going to affect us. And that means that our bones become more brittle. And if we fall, it's more likely that we're going to injure ourselves and break bones. If that happens, secondary infections can set in. Bones may heal, but they may not heal correctly and therefore cause dysfunction in other venues and other ways. So just to keep in mind that these are normal changes. Our joints become less elastic, all those like connective tissues and everything. And that means that it's harder for us to move. It's harder for us to move quickly. And it's easier to kind of snap things or pull things out of position and cause some damage there. For our organs, they become less efficient over time. So like our lungs and our lung capacity, our heart and its reserves, those shrink. And therefore, if we are having to be in a prolonged state of fight or flight, we're not going to have as much energy to do that as we age. We'll have less endurance. Our reaction time may decrease for a myriad reasons. Processing may take longer and reactions lag. And that's a lot of it having to do with all of the other changes that we've discussed. So when that happens, again, we're less likely to be able to defend ourselves. Our senses are also going to change. Our senses are how we interact with the world. So when they change, our ability to interact with the world also changes. And it's a lot harder to adapt to that the older you get, because you get more used to, you have more pathways that have been doing something the same way for the entirety of your life. It's harder to learn new things as you age. It doesn't mean it's impossible. People do learn and have the capacity to learn pretty much throughout their entire life. It does take a little bit longer. I liken it to a computer, right? The longer you have a PC or a laptop, PC, I'm dating myself now. The longer you have a laptop, the more files and everything get on there. And even if you delete old files, there's still little remnants of things that get stuck in there and clog up all of the RAM, right? It's the same with our brains. It's still there, it's still working. It just may take more time to pull it out and pull it to the forefront. Also, you know more as you age. You've learned more, you've experienced more. So there's so many different files in there, and all the little minions in your brain that are trying to pull those up are like, okay, this is just, there's a lot here. It's going to take me a minute. Changes in sensory include things like hearing. So almost everyone will experience some level of hearing loss as they age. Now, the higher tones tend to go first. So just to keep in mind, if you're talking to someone, if you are a cis female, or if you are even a trans woman as well, trans women also would have, given different hormonal changes and everything, if you have a higher pitched voice, it may be harder for individuals to hear you. So sometimes I really do end up having to talk to someone a little bit at a lower register to try to get them to hear me, because especially if I get excited or start talking too fast, I start to get a little bit higher in my octaves. That makes it harder for people to hear. So just to keep in mind, the register of your voice can be harder to sense for people who have some level of hearing loss. Our vision can change. Presbyopia, the bottom one there, that is simply age-related eye strain. So essentially your lens becomes less elastic. So it's harder for it to kind of focus in and focus out. So people become farsighted, meaning that, that's when you see the people that are trying to like read their phone or read the menu and they have to hold it farther away. And that's because of presbyopia. It means just a small change in the eye. There's also things like cataracts. Cataracts, there are interventions for. You can reduce cataracts, you can eliminate them and bring someone's vision back to average. But for something like glaucoma or macular degeneration, there's not much that can really be done for those. So a person's vision can change over time. And again, touch does also get diminished. Taste gets diminished. All of those things. So for me, I am a foodophile. I love eating. I love food. It brings me great joy. And a lot of what we do, and as we'll talk about isolation and everything, eating for human beings is highly social. It's a highly social thing. For me, it's not. I don't care where I am, just give me the food, I'm happy. But for most people, for most normal humans, Eating has become a social engagement. If you are not deriving any pleasure or joy from eating, or if it's painful for you to eat because of different changes in your mouth and dentition, then you may avoid going out and eating, and therefore you may avoid interacting with other individuals. So it's just all of these different things that change. And it doesn't mean all doom and gloom. All change is not bad or wrong. That's not the case, but it is different, and it needs to be acknowledged in how it can affect people's ability to interact with their environment and their level of possible injury. So I do want to talk about one of the elephants in the room, and that's dementia. Again, I think one of the largest stereotypes that I encounter in my advocacy with older adults is that if someone reaches a certain age, then they must have dementia. The fact of the matter is that's false. Most people don't develop dementia. So dementia is a cluster of symptoms that affect a person's cognitive abilities. There is a bunch of different realms that this can affect, much like our physical bodies, right? So there's executive functioning. So my ability to think about, unlike my ability to make this sentence right now, to plan and execute a plan, to make a plan and execute it. That's executive functioning. We also have memory. We also have math ability and literacy and speech and hearing and perceiving and sensing. All of those things are different portions of the brain, all of which can be affected by dementia. And symptoms and severity vary person to person. Alzheimer's disease is the most commonly referred to form of dementia. It's the most commonly diagnosed form of dementia. Some forms are temporary, and proper care can reduce symptoms of dementia. So when we look at someone who has dementia, but they're getting proper nutrition, they're getting proper health, their medications are managed appropriately and well, they fare much better than someone who's not getting proper nutrition, who isn't eating the right foods, who isn't being given enough fluids during the day. They will have two very different outcomes for the most part. So we can mitigate those. Also, sometimes dementia can be exacerbated by physical issues. So ultimately, a medical diagnosis is necessary in these situations. Dementia can be permanent. Some forms of dementia are not, so reversible conditions would be that medication mismanagement. So for example, if someone has vascular dementia, so parts of their brain, the blood vessels have been affected, reducing the blood flow and then cutting off some of the ability for that part of the brain to grow, flourish, and develop, right? So vascular dementia, but they're also having a medication mismanagement. If we start to medicate, and that's making everything worse, right? If we can control and reverse the medication mismanagement, then the vascular dementia won't be as severe, or potentially won't be as severe. So we can kind of cut off some of the lower hanging fruit there and prune it a little bit, right? Malnutrition, drug and alcohol misuse, so we have a geriatric addictions program here, and the most common form of substance misuse that is seen in that program, or historically has been seen with older adults, is alcohol, but that's starting to change, and we're starting to see more and more opioid use, more and more other hard illicit drug use, more and more marijuana use, although that's always been pretty steady too. So just keeping in mind, the opioid epidemic started back in the 90s when pharmaceutical companies were basically force feeding a bunch of lies to physicians, saying this is a beautiful drug that doesn't have any negative side effects, and look at how effective it is on pain. So in the 90s, there was enough opioid prescriptions filled to provide like every single American with several different, like a dozen pills. Like, I mean, totally too many prescriptions out there for opioids. And thinking about, you know, people in the 90s who were in their 30s, 40s, 50s are now our older adults today. And those individuals may have had an addiction that's lasted that long, that started, most of those addictions have started because of prescriptions. So older adults still have those prescriptions, and they're still the most likely to be prescribed opioids. Now, not only can the opioid use or misuse affect a person's cognition and different things about their physiology, but it also makes them a target for others who have substance misuse going on in their lives, they know that it's there, they know that that's where they can get it, so they may target the older adults, so they may be more vulnerable to other crimes and elder abuse as a result of that. Infections, urinary tract infections, they stink no matter how old you are. They're the worst, right? For older adults though, they have cognitive changes that develop. When I have a client and there's an acute change in their cognition, or someone reports to me that there's an acute change, my mind immediately goes to a urinary tract infection, because those are nasty for older adults. And they're also very common because, again, going back to the brittling of the skin, the loss of the fatty or adipose tissue, all of those things, infections become a lot more easy to accumulate over time. So the different types of dementia, Alzheimer's disease is largely a global decline in function. Vascular dementia may be very targeted because it just depends on what part of the brain and the vessels to the brain have been affected. Lewy body dementia is an incredibly aggressive form of dementia, and you will see people that will precipitously decline if they have that. Frontotemporal dementia often results in personality changes. The frontal region of the brain is where a lot of that upper level cognition happens. So if that gets damaged, you may see people starting to quote unquote act out. They may become sexually aggressive. They may become otherwise aggressive. They may say things that they wouldn't have said 5, 10, 15 years ago, but now they're saying it because they don't have that filter anymore. That can be a sign of frontotemporal dementia. There's other forms as well. There's a bunch of forms of dementia. Those are really kind of your most common forms. But other considerations also need to be taken into effect, right? So trauma, elder abuse. Do we think that that's traumatic? Of course it is. Literally, it is the definition of trauma. Any form of elder abuse is trauma. We do not react well to trauma. We cannot always be in a totally quote unquote rational mindset. It might be perfectly rational, but to the outside world, there's a lot of judgment there, right? If someone's acting in that fight, flight, or freeze response, like there's so many different times where it's the whole point of trauma-informed responses is to take it from that what is wrong with this person to what happened to this person. And that's an important distinction, because right there, you're already changing the narrative and how you can respond to an individual in a nice manner, in a kind and conscientious manner, and in an effective manner. Mental health. So there are some mental health issues. Sometimes, especially like schizophrenia or anything that would cause hallucinations, that can really mimic a lot of dementia as well. And sometimes those can interplay, and it's really hard to figure out where the mental health issue begins and where it ends in regard to the dementia. So, because people with dementia can sometimes suffer from hallucinations. Parkinson's, dementia from Parkinson's, there's a lot of hallucinations associated with that. It's very common. But a lot of the time when someone's talking about flying squirrels in their house, as one of my clients did, which granted really could be a possibility, but in this case it was not. People in the walls, people in the ceiling, stuff like that didn't exist. It was due to the Parkinson's. But someone maybe coming in that doesn't know that she has a Parkinson's diagnosis might immediately go to mental health. It's important that when we look at someone, we look at the whole picture and we start to bring in all these different pieces, and we have the knowledge base to say, just because it looks a certain way doesn't mean that it is a certain way. And that's just good in all life, but particularly with older adults, I like to bring these points up because it's a population that not a lot of people are comfortable with and that not a lot of people work with. Strangulation, I bring that up because not only is strangulation super duper deadly, but also strangulation can mimic some forms of dementia as well, because literally oxygen is being cut off to the brain. Therefore, you will have a cognitive response to that. With older adults, the assumption always goes to dementia. It may not be dementia. And also just the way that swelling and inflammation works, older adults, anyone, if you are strangled, the injuries may not be external. There's not a lot of bony prominences in the neck. So bruising to the neck in general is not a common sign of any sort of natural function, okay? And a fall or whatever, your neck is pretty well covered and pretty well, defended. So injuries to the neck, if they are visible, very big sign of abuse. They may not be visible because of the lack of bony prominences. But inside the throat, if that starts to swell, it's not going to necessarily happen right away. There may be a delayed response. but a person may be strangled to death even when there's no external force being inflicted upon them. So just to keep in mind, looking at all the signs, are there petechiae hemorrhaging? Is there, any sort of bruising along here? Like, what are we looking at and what do we see? Do we see handprints? Because sometimes you will, but not always. So just keeping in mind that if someone has been strangled, it can present in some ways like dementia. And also, it's really important to get that person into an emergency department or under medical supervision and care as soon as possible, because they can die within 24 to 48 hours just from the delayed inflammation. Communication challenges. Communicating is hard, and especially in the time of COVID, communicating is even harder because you're not getting all the nuanced body language, all the facial expressions. They're not coming through as clearly as they would if you're sitting face to face with someone. If someone has low vision, if someone or is blind, if someone is deaf or hard of hearing, all of those things can affect a person's ability to communicate with their outside world and can also affect their ability to receive information. And that can also be manipulated by caregivers and unscrupulous others who are already preying upon the fact that professionals often defer to the younger person in the room versus the older person in the room. So communication issues just can make that even more of a challenge. Also, language barriers. There's been so many different situations with language barriers where they are not treated appropriately by the professionals in them. And kind of the best advice I can provide is to get a professional interpreter involved as soon as possible. Relying on family members or friends may be the easier path, but things will get lost in translation. And anytime you're talking about any sort of legal or healthcare concerns, there's nuance to that language and literacy levels with those two topics specifically that may not be understood by the lay person. So having an official interpreter is important. That said, there are sometimes pockets of language in a certain area where you cannot possibly find a translator who doesn't know the survivor. That's an issue. I mean, there is the language line then, and I would recommend doing something like that, but trying to get a professional translator in as soon as possible. Developmental disability or intellectual disabilities, that's another thing that can mimic dementia, sometimes, especially with older adults. Back in the day, when older adults were in school systems and whatnot, there weren't as many regulations, there weren't as many diagnoses things being identified or diagnosed. And people weren't necessarily going to school beyond 8th grade in some cases, or 6th grade even. So the chances of them having received a diagnosis prior to the age of 18, a lot less than it would be nowadays. Therefore, they may not technically have an intellectual disability because they weren't diagnosed at the quote unquote correct time. So because of that, I think there's a lot of individuals who could really benefit from OPWDD services and that whole litmus, but unfortunately can't necessarily access it except for under extreme circumstances because of that lack of diagnosis. And it also can just mimic, some portions of that can mimic dementia, right? So we never really know. And then mild cognitive impairment. Mild cognitive impairment is kind of a precursor to dementia, but it doesn't always develop into dementia necessarily. Just another diagnosis that you may come across and may hear. Capacity, quickly, is a legal definition. There is healthcare. Someone might say that they don't have competency or capacity in a healthcare setting, and that's very important for certain things. But from a court of law's perspective, for a guardianship or alternate decision making, it's really a legal matter. So just to keep that in mind, people can make decisions unless a court of law has said not to. So now some of the challenges that we're seeing with older adults during COVID-19, because there are a lot of challenges. One is an increased level of isolation. Isolation is already incredibly common for older adults for myriad reasons. And it's also one of the greatest, what's the word I'm looking for, causes of elder abuse, or the circumstance, I should say, in which abuse can and does occur often. You know, it makes sense. If a person doesn't have many others in their life, they may be more dependent on the one or two that are in their life, regardless of if they're people that are treating them poorly. But also, if someone doesn't have anyone, then it's easier to get into their life and to get it ingratiated to them. And then there's fewer people that may see the signs and symptoms, fewer people for the person to reach out to for assistance. So contact with others is jeopardized as well during COVID. So if someone has a health issue, if they're, any older adults are already at a higher risk category. And a lot of family members have their own health risks or their own children, so they're fearful of bringing COVID into their parents, grandparents' homes, right? So even the quote unquote good and healthy relationships in the individual's life are jeopardized because those individuals are worried about bringing something to the older adults. Contact with hairdressers. Here's the thing, friends. Okay, you are going to tell the people who hear all of your dirty little secrets are not necessarily family and friends. They're your priest, they're your bartender, and they're your hairdresser. Those three entities know faith community leaders of any form. They know everything about you, right? You talk to them about things that you are never going to say to anyone else. They know. Now, bars are very much not really functioning right now, right? Not in the same way that they used to. And certainly everyone has masks on. Most bars are kind of loud. So it's hard to have a conversation with a mask on when you have to shout and there's so much chaos going on. Hairdressers, they're open now, but not everyone is utilizing them because of concerns, again, about COVID. And most faith communities are going remote, are not in person right now. Or if they are, we're seeing that there's a lot of pockets of COVID outbreaks resultant from faith-based gatherings, which is very unfortunate and sad and scary. Technology limitations. Now, older adults can and do use technology. That does not mean that all older adults, or all younger adults for that matter, are able to navigate the complexities of our online personas and our online existences at this time. Also, if you look at some rural communities, there are tech deserts, right? So places where there really is no way to easily and cheaply and affordably get an internet connection. And while that's surprising in this day and age, it's a fact. So if an older adult doesn't have access to the funds needed to get an unlimited phone plan, for example, or to get a network extender or something else that might help with those things, then they are effectively cut off from everyone else. Also, it's harder to talk, it's harder to hear, it's harder to converse with someone. There's questions about privacy. So technology is great, it's wonderful, it's amazing that we get to do this, and in so many ways we're reaching more people than we ever would before, but we're also not. So just to keep in mind that just because some people have more access, not everyone does. And availability of in-home care is reduced, as well as volunteerism being down for very obvious reasons. It's getting really, really difficult to staff skilled nursing facilities, assisted living facilities, and particularly home care. We were already in a crisis situation with having enough aides and CNAs and nurses and social workers too, to go into people's homes and to do this work. Because unfortunately, aides they're paid minimum wage to do some of the hardest work in the entire universe. And unfortunately, we've had a lot of gaps in terms of availability. So people, even if they are supposed to be getting 8-12 hours of aid a day, 4 hours of aid a day, a lot of the time people are calling in sick, they're calling in for other reasons, they're just not showing up. It's hard to cover shifts. It's very hard to cover shifts. And especially now, there's an added concern about safety for both parties. And people are getting thrown into situations where they are having to care for family members who, kids who have been displaced from daycares or from school, people who are losing their other jobs and need to focus on family or have to go on unemployment and are unable to do this stuff. So it's really a very challenging time. And even prior to COVID, it was a challenging time, particularly because of the low pay. Okay. Also, increased contact with the perpetrator. So interestingly, while domestic violence numbers seem to be skyrocketing, and while I think child abuse too, but I don't know how the reporting is going. I'm not as familiar with that realm. And stalkerware or spyware numbers are through the roof, like hundreds of percentage points higher now since March than any other time, because that's what people apparently do during pandemics, is stalk others. COVID-19 challenges and increased contact. So increased contact with the perpetrator. If the perpetrator is out of work, let's say the two live together, or even if they don't, if the perpetrator has lost their job, or if they already lived in the home with the older adult, and now they aren't going physically to work, working from home, out of work, unemployed, laid off, that's an issue because now they're home all the time and there's no outlet. If the perpetrator is taking on additional caregiving roles and they're kind of thrust into that role with an already strained relationship, caregiver stress does not cause abuse, but it is the context in which some abuse occurs. And if you're taking away a lot of the support systems and a lot of the natural resources that are available to caregivers and expecting them to be able to perform all these duties, you're going to see some issues there, whether or not it's an intentional neglect thing or an active neglect thing or a passive neglect, whether or not it becomes physical or sexual abuse, if it's emotional abuse, all of the things can occur. Financial exploitation is going to be on the rise because if people have lost their jobs, then that can be, they find another way to get money, right? And there's few alternatives for housing. So one of the unintended consequences of all this, it's wonderful that there are these protections for evictions. That is amazing. It's great. However, for my clients, for my older adult clients, the problem is that if someone is living in their home and it doesn't rise to the level or the relationship to get a family court order of protection, then a lot of the time we rely on an eviction. So we can get someone out of the house that way, but evictions are halted right now. So we aren't able to utilize that as a tool to get an unscrupulous individual out of the older adult's home. Now, also trying to find housing for older adults is limited as well. There's a lot of challenges associated with that. Because again, even prior to the pandemic, affordable housing, for example, and subsidized housing was already at a limited amount. It was already a challenge to get people in because there's not enough of it. Now, nursing homes and assisted livings are another story altogether. And folks are really reluctant to have new individuals coming in because of the concerns. So there's not a lot of places to be putting people other than together. And if that's not safe, then that can be a challenge. So some of the things that we've been able to do here, and hopefully even if it's not a one-to-one correlation, it's something that can be extrapolated and potentially used by others. Increasing phone calls by Lifespan staff and volunteers. So we've been calling people more. We've been checking in with them to see how they're doing. New clients, old clients, it didn't matter, especially when this first started, we were calling people and contacting them. Now, the beauty of it for my program is that I didn't call people as Tracey Siebert-Konopko, social worker in the Elder Abuse Prevention Program. I called them as a social worker from Lifespan. So I was able to just say, hey, we work with older adults. We know that there's this pandemic going on that is affecting older adults differently than it's affecting other populations. How are you doing? You know, what type of things are you seeing? What kind of assistance could you use right now? And that can elicit a lot of really important information. And we'll get to what you can do if you're not an organization that has more generalistic services, right? So outreach letters from Lifespan, we also did a lot of that, a lot of educational pieces, particularly as it pertained to like the census and the stimulus. So to try to get people better informed as to what to expect from those things to reduce the amount of scams that are available. And again, we're not really talking about scams today, but it all is related. Volunteers, we've had people bringing food to folks and essential other items to folks as well. And it's kind of an easy reason, a crisis, a global crisis like that is an easy reason to make an excuse to reach out to people. Now, one of the ways that you can accomplish that if you are not part of a general program is to collaborate with other different organizations. So to collaborate with the Office for the Aging in your county, for example, with New York Connects in your county, and see whether or not they would be willing to either do some collaborative work or even provide your brochures or your contact information to people when it's safe to do so as an option. If they do an entire litmus, a range, if Offices for the Aging are releasing information regarding all resources in the community, ensuring that sexual assault and domestic violence programs are a part of that. That's really important, right? And it's possible. If they're adding a list of resources in general, why not have that? New York Connects already has that on their sites, right? So New York State Office for the Aging and Adult Protective Services in your community. That's another place to link up and link arms with to really collaborate on this. So I also want to share with you another thing that I found to be kind of a cool way to get in the door without being threatening. So this is a disaster preparedness document, brochure. This is specific to if a natural disaster or something along those lines occurs. This is not designed specifically for elder abuse, intimate partner violence, or that. However, a lot of the tips and tricks in here are things that really are very similar to a safety plan that you would develop with someone. But this is an easy way to do it that doesn't say, hey, domestic violence safety plan. So, you know, if power is lost, a pet or service animal. Pets are one of the biggest reasons that people don't leave, right? Because what am I going to do with my pet? Also, my pet is my life. You know, it's a big concern for folks. Well, this has that right on there. Some suggestions and things to get people's thoughts moving. So one of the best pieces of advice I've ever received in regard to acting and reacting is that your body will never go where your brain has never been. So getting people to think about these things and critically problem solve it in their head so that they're not trying to pull it all out of nowhere, out of the nebula when something does happen. So if this is helpful, I can send out a PDF that can be utilized. But I thought that this was kind of a cool way to be innocuous and to get a foot in the door and get the juices flowing towards a certain agenda without it being very clear and obvious. So it can be a little bit more subtle. Providing direct interventions. So for caregiving services, seeking paid in-home services whenever possible. Now that doesn't mean that a paid caregiver that's not a family member is not going to abuse someone, but there's more controls over that. The person can be removed from the older adult's care. They can be, you know, they can be prosecuted a little bit more easily than a family member could be. So it does make sense. There's more protections there, more people involved. And anytime you can get more eyes on the situation, the better. Considering shelter options in Monroe County, we do have an elder abuse shelter. It has been very challenging because of COVID to get people into our shelter, because it's a virtual one in Monroe County. We have partnerships with several area nursing homes to provide temporary stays. So our respite in general, we also have a generalized respite program that can put folks in hotels if it's safe for them and appropriate for their level of care, assisted living, all of those type of things too. It is a challenge during this, but it's not impossible. And I know our domestic violence shelter, the residential provider Willow in Monroe County, their shelter has never closed. They continue to offer that to folks. So whatever's appropriate for the care and the position that that individual is in, it's all possible. It just may take a little bit more work. Consider other housing options. Orders of protection, we can still be doing those. And you can also connect with the New York State Coalition for Caregivers, Caregiver Resource Coalition. There we go. Acronyms for days for support for caregivers during this time too. Now, I don't know how often you're going to be in contact in your professions and in your positions with the caregivers of older adults, but it's just something, even if you're talking to an older adult who says, hey, my caregiver has been doing X, Y, and Z, maybe they can even go to the site and get some tips and tricks, you know? So it doesn't hurt. More information is almost always a good thing. Opportunities, one size does not fit all. There's nothing that I can't stand more than seeing something that says one size fits all, because chances are that it's not going to fit me. And then I just feel sad and upset and not happy about that. So I think that that's kind of everyone. I think that, you know, people don't want to be fit in and lumped in with everyone else all the time, right? So show up your defenses, again, linking with other organizations, working with the person from a trauma-informed response perspective, where we're really asking them to be empowered and to collaborate with us and work with us, not for us, right? Because that's how it comes off a lot of the time. And I know that, you know, in my youth and in my earlier years of practice, it was more like, well, this is what you should be doing, which was never good social work practice. And I had to really breathe that out of myself, because it's not productive. And especially with older adults, chances are they know more than I do. And they know more about their situation than I do. So I had to kind of remind myself to be a little bit more humble and less ridiculous for 5 seconds. Consider collaborating with Meals on Wheels and Senior Center. So Meals on Wheels, great opportunity to go out and get some information. Even if it's like a ride along and you can go and see people and just introduce yourself, that can be really powerful. You know, we see that with law enforcement often too, is that that's one of the ways that they try to get in with the community, is to do ride-alongs and whatnot. Connecting with healthcare providers in your region, which I believe that, you know, most domestic violence and sexual assault programs will do anyway. It's kind of one of the things. Utilizing New York Connects. Again, New York Connects is available. It's an online thing, but it's also a phone thing. It's within every county in New York State, and it's kind of your one-stop shop for all aging needs. So it's a really good resource tool. It's a good way to get some information about programming that is specific to your region and your area. So I always recommend that people go to New York Connects for assistance with that. If you have the ability to do the remote orders of protection, I'm not sure. I know that for a while their remote orders of protection were, it was a pilot program. So not all communities had that available. And I'm wondering if that's changed since COVID. And I'm guessing that it probably has, that most places can offer that. So trying to link up with that whenever it's possible. And then preparing for the flood. Make sure that when we are preparing ourselves, because we don't know how long this is really going to last. And we don't know how long until we get another uptick in cases, right? We're talking about the fall and the winter now, where more people are going to be indoors, where there's a bunch of nasty things that go around in the fall and in the winter. And granted, we're taking more precautions in terms of covering our faces, washing our hands, and socially distancing, which should reduce it, but we can't guarantee that we won't have a surge in numbers. And once you start doing more outreach, if you are able to do more outreach in your community to older adults, you may get an influx of referrals. We have had actually a lower number of referrals. We're down a couple from our average each month. And I'm not really entirely certain why that is, but my guess is that it has to do with the fact that most of our referrals come from healthcare institutions, from non-abusive family members and friends, and from other organizations and professionals where the older adult isn't being seen right now. So they're not going to their primary care physician's office as often. They're not going to their hairdresser as often. They're not going and visiting other family members, and family members aren't coming and visiting them. So like we would always see an uptick around holiday seasons, because once family came in from out of town, it's easy to tell people over the phone that things are going great, things are going wonderful, but then you go and see your family member and you see the deterioration of their environment and of their person. And it's like, okay, things are not as good as you said that they were, but people aren't traveling so as much as they were. So there's fewer opportunities for these concerns and for elder abuse to get detected by professionals in caring others. So we're not seeing an uptick in cases currently locally, but I do think that that's going to be an issue going forward. So we have to kind of shore up our defenses and make sure that when that does happen, that we're able to competently and compassionately allow for that, but also caring for ourselves, because everything is hard right now. Everything is hard right now. Let me see, keep going. Again, the helpful contact information. So essentially, that's it. We're done. I do want to, I'm really curious though, because I would love to have some information from you all. Now, I've been in this field for 12 years. I have had one case that I knew that was referred to me because of sexual abuse. I do not see many cases. We did have a case locally that was in the newspapers and everything of an older adult who was victimized by, who was a survivor of sexual assault from a neighbor. And that neighbor had already been convicted and in jail for assaulting someone else in the past. And the way that he went about that was to essentially befriend her and help her around the house. He was super duper helpful for things that she needed to get done. She was never married, you know, she was single, and she just kind of didn't see what he was doing. And the way that he manipulated her was that he really truly cared about her and that he was helping her, and that this is kind of just the natural thing that happens when you help someone, is that you then have sex. So unfortunately, he really took advantage of her and treated her very poorly. And luckily he was able to be prosecuted, but that's not the norm. I don't see cases of sexual assault very often. Some of that is my own lack of ability or lack of questioning. I definitely know I need to get better about asking the questions, because it's not easy to ask those questions, especially with older adults. It's just, you know, there's a different level of culture there. So I'm really wondering how often folks on this call, and feel free to pop in the chat or to take yourself off of mute, how often do you see older adults in your professional world? Bueller. So
I guess, I don't know if you guys can see me or hear me.
I hear you.
Okay. So my name is Alexandra Vukucevic. I am an intern at Jewish Family Services, JFS of Ulster County. I work under Sharon Cohen.
Yes.
And yeah, so I'm a Columbia University grad student in social work. So we are, because my track is advanced clinical social work, us interns are doing remote therapy, you could say virtual therapy, with the aging population, so 55 and older. And so we're not seeing them like I used to last semester work at the same place, and I used to go and we used to do in-home counseling. So we would see, I had a couple of clients I would see on a regular basis. But unfortunately now, like you were saying before, it's hard to really determine the whole environment and what's really going on. I'm getting background on the client I'm going to be working with this semester, so I haven't yet had an interaction, but I will be having a lot. So this information has been really helpful for me to know what resources I have. Of course, I have people like my mom, you know, she's in her late 70s. So I have interaction with her. Again, unfortunately, she lives in Florida, so it's like over the phone. And my late dad, but you know, he's no longer with us. So I guess it would just be on the professional front. It's about to come where I'll have a lot of interaction with him, and on the personal front, it's mainly with my mother. So
yeah, thank you.
But a lot of this really got me thinking. I didn't know a lot of the information that you put forth, like the legal responsibilities versus the ethical ones. I wasn't even aware that there was differences between the two, and then I also didn't realize that, you know, financial is one of the most prevalent forms of abuse. You know, you would think it's verbal or, you know, physical, but it's the subtle ways in which people are abused that sometimes the invisible ones, right? Like invisible ones. So thank you.
Yeah, I mean, in our program alone, about 75% of our cases are either primarily financial abuse or secondarily financial abuse. But it is the most prolific form of abuse that we're aware of. Now, sexual abuse is the least commonly reported, but I think that it's also just not commonly reported. It's not that it's not out there.
Right.
It's that people are not bringing it to our attention, and we're not asking the right questions to elicit that information either. And it's kind of like being in an emergency department, right? There's all these other things that may happen, but you're kind of treating the acute issue that brought you into the emergency department. And that's kind of where we are. So if someone's not telling us, then we're not asking, which is not to put that blame on that individual, the reporter. We need to get better about asking it. It's just not our knee-jerk reaction. Okay, so I see Elaine. Hi, Elaine. Said that she sees folks regularly. Yep, you would. And okay, Nancy says that she's an elder law attorney at Legal Services of the Hudson Valley. Awesome. You guys are awesome. You folks are awesome. All of their clients are 60 and over, never had any indications of sexual abuse with regard to clients. Yeah, I know it's something that we just, and here's the thing, friends. Again, I absolutely am not professing to be, I need to do work here. I absolutely do. And I think as a society, we need to do work. Because if we think about the challenges that younger folks face when they come forward about sexual assault and sexual violence, it's not fun for anyone. It's particularly not fun for folks who, when intersectionality comes into play, right? And older aging is an ism. There is ageism, right? There's a lot of folk that are incredibly incredulous that could ever even happen to an older adult. Some of the things that I've heard people say are flat out disgusting and horrifying to me. And well, to anyone with, a conscience. So it's incredibly important that we do know that this does happen to older adults and that they're less likely to come forward because they grew up in a different time where sex was not talked about as openly or as often, where something like marital rape didn't even exist. I mean, it did, of course, it's always existed, but it wasn't something that people talked about or that was, a thing. Sexual harassment, again, all of those things that we've really come within the past, like even just decade,
Right.
To really come to the forefront and talk about are things that are in many ways novel to a lot of older adults. Not all older adults, but a lot of older adults. And, and also the stereotypes and the judgments made because someone is older. So it's a prior private sector job, saw an instance patient. Yep. So the one case that I did have was in a skilled nursing facility. Now that's not at all a surprise to me because folks who are in skilled nursing facilities are more likely to be identified because there are more people around. That said, it's also often that there's a huge delay in the response because there's all these internal things that end up going on first, internal investigations and whatnot that end up happening before law enforcement gets brought in. So therefore, a lot of evidence gets completely eradicated. And that's a problem. And a lot of the time, if there's not definitive proof, then it doesn't go anywhere because, well, we don't know that it did happen, but we don't know that it didn't happen. But Jill, hey Jill, works for Vera House. We love you too. Although it's not frequent, we did see older survivors of sexual assault and abuse. Saw 1 or 2 a year. Yeah, I mean, I think that's probably about average, 1 or 2 a year. And that's concerning to me. So everyone on this line, if you have not seen a lot of older adults, then I think it's probably important to really take to heart some of what I have said in regard to working with your Office for the Aging and Adult Protective Services locally and trying to get inroads in there because these cases are out there, but no one is seeing them or very few people are seeing them. And that's problematic. So we have had to do, we're always talking about ways that we synthesize and how we outreach to people, right? One of the things that can be helpful in outreaching is ensuring that older adults are represented in literature and represented in any sort of visual formats. So on program thingies, brochures, hello, signs, any sort of advertisements on the cover of your reports, all of those type of things, anything where the public is going to have an interaction with you and is going to be able to connect with you, ensuring that there are older adults represented too. Just like we would say about a lot of our underserved populations. Older adults are an underserved population. So any other thoughts? Yes, Crystal.
Hi, I'm Crystal Peters. I work with Family Service, Elder Abuse Case Manager. So we are just getting our information together, and tasked with the challenge of getting our information out into the community. I do think that there are cases, but maybe some individuals don't see themselves as victims. We're getting them, but they're slowly trickling in as referrals. Some of the ideas that you gave with Office of the Aging, Meals on Wheels, and New York Connects, those are great ideas that I probably will definitely implement as we think about how we're going to outreach and get our information out there to the community.
Awesome. Yeah, I love working with this population. I love working with older adults. They're my favorite. I really could not have ever worked with a different population. This is where I want to be. And it is flooring to me how few others really do end up being like, hey, everyone goes into, and I get it. Like, I mean, children are amazing. Kids are awesome. I personally never wanted to work with kids. I didn't want to work with people my own age. I don't like people my own age. I don't like myself half the time. So like, no, I like older adults. It's a good population to work with. And I think it's also still a very underserved, it is a very underserved population. And it's so cool to hear all of the different programs. When I started 12 years ago, a lot of the programs even that have come and said stuff during this really didn't exist the same way that they do now. And it's so cool to see that progression over time. So it's exciting to me. I get excited. I'm like, yay, there's things that we're going to be able to do. There's things that we can, change and really affect and make sure that we're serving people and allowing access to people, regardless of any of the demographic details that have often limited their abilities. And again, ageism is prevalent. And you know what? We all engage in ageism on a regular basis, including myself. I'm 100% not immune from this. It's an easy joke to make, right? Getting older, I'm too old for this, all of these different statements that are not positive. It's not malicious, but it also isn't a positive image. So that's another thing that I think needs to be worked on, is how we phrase and how we categorize and market, how we market things to folks. So, another thing that I've been hearing a lot about is like reframing elder abuse, because just like you said, Crystal, people don't want to think of themselves as being a quote unquote a victim, right? They don't want to think of themselves as being an older adult a lot of the time. When people hear the term elder abuse, they're like, I'm not an elder. And then they hear abuse and they're like, oh no, no abuse, And that's where it kind of sometimes gets more helpful to talk about respect. How do you feel, how do the people in your life show you that they respect you? Do you often feel like people in your life are not respecting you? And in what ways? How does that look to you? And we want to make sure that everyone has access to justice, to systems, to this, to that, wants to have access. So trying to reframe it a little bit sometimes can also be helpful, especially if you're doing outreach and you want it to be a little bit more innocuous. Going towards more of a respect route has a broader distinction and a broader meaning, but it can still drill down. And I always say to people, one of the questions that I like to ask is, how safe do you feel in your current environment? And you want to know what? I don't care if someone says my roof is leaking and I don't feel safe. Great. That's something I can still help you to find assistance with. I can still connect you on that level. It doesn't have anything to do with my program, but I can absolutely help you with that, even if it's not directly. So no information and no report of concerns is a bad or superfluous concern, right? It's all something that is significant to that person and potentially intervenable. So, keeping it open and keeping it general, there's no problem with that. You can always drill down and ask more specific questions if you need to.
I had another question. This is Alexandra Vukicevic again at JFS. I was wondering if you could also, on the topic of ageism, if you could also speak to ageism and how it occurs in the workforce. I know that there are a lot of people who enjoy working past a certain age, and even though they're told, okay, this is your retirement age, they are still fully capable. Like you said, dementia does not happen to everybody.
Right.
And they're physically willing and able to do the job, and mentally and intellectually. Can you speak about how does that does that translate to discrimination and abuse when it's done in the workplace? And how do organizations like you could, or all of us here on this call, how can we help with that if we do witness that? Or is that just like a legal thing for a legal entity to handle?
All of the above. So, yes, age discrimination in the workplace is prolific. And I believe that it starts at age 50 and maybe even earlier in some cases. So 50 is not old. I mean, at all, so, and probably many folks on this call are close to approaching at or just over 50, right? And unfortunately, there's a lot of reasons that this has happened, one of which is just straight up ageism, simply. And ageism doesn't necessarily refer to older adults necessarily, but just there's a lot of expressions of ageism, particularly as it pertains, and I'm speaking more from personal experience here, as a female. It's like our sell-by date is like at like age 20, you know what I mean? Like it's like anything beyond that, and there's like all these things that are marketed towards us because we have too many wrinkles and we have too many of this and we have too many of that, and we need to keep ourselves younger. We can't possibly age. Aging is verboten. So I mean, not that doesn't also happen to men, but it definitely is marketed towards women. Anyway, but I digress. So with employment and whatnot, what we see a lot of the time is also difficulty in hiring. So agencies don't want to invest in bringing someone up to speed and whatnot that they think is just going to retire in a couple years. They also don't want to pay. So like if you're a nurse, for example, and you get laid off, or let's say you take some time off of work for whatever reason, and you try to get back into the field or move jobs, you're not likely to be hired, because dental hygienists, that's another one, because they can hire someone fresh out of school for a fraction of the price that you would pull. And they feel that they're going to get more of an investment on their, or more of a return on their investment, because they'll have someone that can be within the program for longer. So there's definitely difficulty in hiring, but also in retaining jobs. There's a lot of things that are kind of subtle to push people out, encouraged early retirement, threats to the retirement. If you do this, then if you don't do this, then you're going to lose out on this. There's incentivization, which is like, I understand some of the reasoning behind that, but the messaging is kind of off, isn't it? So we're incentivizing you to leave to make room for the younger folks. Ouch. And ew. So there's a lot of different things. Most of it probably doesn't come to a legal situation as it exists. Of course, the civil court being being an easier place to bring that. I mean, from a criminal perspective, probably not most cases, right? Because the burden of proof and legislative burden is just so high. With a civil suit, you probably have a little bit more. So, in hiring practices, transparency is best, of course, and ensuring that when you're doing hiring, that you're including people in the hiring process who are qualified, regardless of their age, just like you would with anything else, right? You hire the person that makes the most sense for the position based on their experience, how they interview, all of those different things that are really important. And then if you see something in the workplace, go to HR. Say something directly to the individual who is doing something. Say, not cool. It doesn't have to be a big confrontation, but hey, I noticed that this was said. I really didn't like that I heard that. It's not kind, it's not this, whatever your flavor is of how you confront people, challenge someone on it. At the very least, if you see someone that is discriminated against because of their age, even going up to them and just starting a conversation, if you don't already have a relationship with that person, to help them to feel noticed and seen and heard, that can be really helpful too. We have to be careful that when we're advocating just in general, that we are not doing something on someone's behalf without their permission, right? So it shouldn't be your fight in that regard, but it certainly is your responsibility to help that person to be seen, to report any sort of inconsistencies or wrongdoing to the appropriate persons, and to challenge those behaviors when you do witness them and when you do see them, and also in yourself, challenging them in yourself, because that's where it starts. So one of the other most amazing things that I've ever heard in my entire life, and I love this so much, in regard to implicit bias and structural racism and isms in general, is that as human beings, we are not responsible for our first thought. The first knee-jerk reaction that comes into our heads, we're not responsible for that, because that's based on external forces, things that we've learned through the years, things that we have observed through the years and sensed through the years. That's societal, that's psychological, that's not something, it's not our choice, that first thought. But we are responsible for our second thought and our first action. So once we notice that we have a negative thought or a judgmental thought in our heads, do we foster that and feed that thought? Or do we say, okay, yeah, that's based on some nonsensical stuff, that's wrong. And then we make sure that our first action is in keeping with that second thought, the positive second thought, preferably. But I love that, because I know as a human being and as an individual that I often take things very like guilt. You know what I mean? It just about anything that can happen. And I'm like, oh my God, stop being a horrible human being right now, Trace. And that's not fair to myself either. And that's also not conducive of learning or of growing, right? Because once you start to even do self-defeating behaviors, you start to get defensive. Defensiveness breeds nothing good in these situations. So being able to kind of let go of my culpability and some of my knee-jerk thoughts was incredibly instrumental in me being a better person. And of course, that's a constant struggle, because as Josie and I were talking about at the beginning of this, humaning is hard. Being a human is just difficult all of the time. So that's one way we can be a little bit kinder to ourselves, I think, and can be more productive in our conversations with ourselves, our internal ones, and with each other. Are there any other thingies that we want to talk about? Stuff.
Will there be another follow-up webinar like this one throughout the year or next quarter or something? Or is this kind of like a one-time thing? Or
Did you have an idea for one, Alexandra? Like, are you requesting, like, what information are you looking for?
well, so that's interesting, because I was going to put that back at you guys, because I'm actually supposed to be focusing on at JFS the Elder Abuse Program and their EMDT efforts. So I was just wondering if this was going to be something that, do you guys get together often? Because I'm new to this. I'm just curious, like, if this is like a one-time thing for this year, or.
This was a one-time thing, but obviously, definitely if there is a subject or something that we can, advance this or do a level 200 one on this, I could definitely talk to Tracy about perhaps doing another one.
Mm-hmm. And there's also,
Great,
so Alexandra, there's also through the EMDT initiative, have you been linked with the financial exploitation webinar series?
Not yet.
Okay, so touch base, really anyone, it's for professionals specifically, but I think it's 9 times a year. So it's not every single month, but most months, there's a financial exploitation specific elder abuse webinar that is offered through the EMDT initiative and hosted by Lifespan. So if anyone is interested in that,
Nice.
Feel free to get in touch with me, and I can absolutely get you in touch with the distribution list for that. Now, and Alexandra, I'm wondering if you're kind of meaning the NISCA or the NISCASA webinar series or meeting. I'm not positive if that's maybe what you meant. Is this specific meeting, is this an ongoing thing?
Yeah, I guess. Yeah.
So
Oh,
then,
okay.
yeah. But also, I mean, I'm more than willing to come back and drill down into any of these topics, or if you'd like to do a collaborative effort at any point too. I'm open to whatever. I clearly have a huge passion for this topic and this population. So
Great, thank you. Yeah, I'll talk to Sharon and see. She probably has other stuff also in stock for us. So I'm just Yeah, we'll be in contact. If you could send me this PowerPoint, that would be great.
Yep.
Thank you.
Yep. I'm going to forward it to Josie afterwards, and then she'll forward it on to the whole procedure.
Thank you.
Thank you so much.
Hello. Oh,
Any other questions?
is saying that their agency saw older adults more often before COVID. Yep. It's been hard to continue to get our information on older individuals who do not have access to technology. Yeah. Oh, you see a pretty even amount of DV and sexual assault in older adults. Let's talk offline at some point. I would love to hear more about that, because honestly, we don't, and it's problematic, and I want to fix it. So, I mean, it's kind of one of my soapboxes, is how no one ever wants to talk about elder abuse and sexual assault and all that. So I'd love to hear more about that. But yeah, I think it's harder to reach older adults during the time of COVID, and yet there are some opportunities there too. And thank you to everyone who's shared, and for everyone who hasn't shared, and thank you for all the work that you're doing, and especially during this time. You know, you're fabulous, you're wonderful. Pats on back.
Any last questions? Okay. Tracy, this has been great, very informative and humorous too. You imagine you have put a lot of humor into this as well. So thank you so much.
It's a coping mechanism.
Absolutely.
Yeah,
Absolutely.
that's one of the kind of hiring practices we have here, is you have to have a dark sense of humor in order to be on our team, because otherwise we're not going to survive this. Like, we need it. So.
Thank you so much.
Thanks, everyone. I really appreciate it. Stay well.
Stay well. Bye now.